Hello and welcome to Checking the Vitals, a podcast powered by SpecialtyCare. I'm Todd Schlosser, and joining me today is Dr. Stephen Griffith, a board-certified neurosurgeon. In this conversation, Dr. Griffith and I discuss how he achieved his childhood dream of becoming a doctor. We also discuss how he developed an interest in movement disorders and how he goes about treating these disorders to great success. We also discuss his approach to dealing with physician burnout. Enjoy the conversation. Dr. Griffith, thank you so much for joining us today. I'd like to start these interviews with a simple question, and that is just, what is it about healthcare that made you want to seek out a career in that field?
Well, Todd, thank you very much for having me on today.
Absolutely.
It's a pleasure to be here to share all this. So to get right to your question, healthcare and becoming a physician was something that interested me from a very early age. I think most boys grow up wanting to be just like their father. And so that's what my dad did. He was an OBGYN physician for over 30 years, probably closer to 35 years or so. But, growing up, I watched what he did. And even though I didn't know much about it as a 4-year-old or a 5-year-old, that was something to which I aspired. And so I remember going on rounds with him when I was 5 or 6. And right after that, I said, you know what, this is exactly what I want to do with my life. I want to become a physician. And then from that kind of larval beginning, it sprung up from there to become a lifelong dream and a passion.
So I'd imagine that because it was very much a lifelong dream and passion, you mentioned 3 or 4 years old there, wanted to follow in your father's footsteps, that when you were thinking about collegiate life and then post-collegiate life, in med school and stuff like that, that was always the path you knew you were going to take. So like throughout high school and college, you knew med school was coming. Is that right?
Absolutely.
Yeah.
This was something that has guided my life and my existence from, the earliest elementary school days all the way through college. Back when I was in 3rd or 4th grade, I would sign my name on my homework, Dr. Stephen Griffith. You can imagine, that doesn't go over that well with your classmates and whatnot. But that's what I did. And I didn't know any better, but it was what I wanted to do. And so I started signing my name that way in my 3rd and 4th grade homework.
Did that continue all throughout your high school and college life, or did you drop that and then wait till you actually achieved that moniker to use it again?
I dropped it rather quickly. But going through elementary school and into high school, a lot of what you did was to prepare yourself for the challenges that you'd ultimately face getting into medical school.
Absolutely.
So even in junior high and high school, I got a little job at the Omniplex Science Museum in Oklahoma, where I was essentially, I think my designation was apprentice or science apprentice or something like this. And we would do shows with liquid nitrogen, and we would kind of take the guest and show them kind of like the tide pool where you have like sea urchins and sea anemones and things of that nature. So these were all little things that we did to get us within the right cohort of individuals that were ultimately going to succeed in math and science and then on into medical school.
Yeah. So you sort of had this honest interest in sciences, it seems. And then I got to ask, when you decided, okay, I'm going to follow my father's footsteps, but I'm going to focus on neurosurgery and not become an OBGYN, how did you come about that decision?
Well, so as far as following my father's footsteps, it was always just the physician route. I knew that I wasn't going to do OBGYN at all. I would always look at the things about the body that I found the most fascinating. And, 2 of the organs that I found most fascinating was the brain and the heart. To me, either one of those things, you've got to have it working very well in order to do well. Yeah. And as I went on and studied neuroscience concepts, I realized that was a much better fit for me. And I liked the intricacies of thinking about it. And later on, as I, skipping forward here, but when I got into the operating room and saw operations for the first time, I immediately knew neurosurgery is what I wanted to do.
Yeah. I talked to a lot of surgeons who, when they're doing sort of, and I forget what they call it, forgive me for that, but they'll like take a mentorship program or like an internship almost, where you like make
a preceptorship.
Yeah, a preceptorship. Thank you.
In year one.
Yeah.
Yep.
Yeah. And a lot of people go into med school not necessarily knowing where they want to focus. And that preceptorship, they'll be like, okay, I sort of like these areas, but I loved, in your case, neurosurgery, right?
Correct,
Some people love
right.
cardiology, it could be whatever, but it just seems like that's how it landed for you as well. Is that right?
Yes, that's right. In medical school, year one, I did a preceptorship with a neurosurgeon who was a community neurosurgeon, doing pretty much the basic meat and potatoes operations,
Sure.
microdiscectomies, laminectomies. And I spent a week with him, but it was transformative in many respects, in that for the first time, I saw myself getting closer to becoming a neurosurgeon, or getting along the path to become a neurosurgeon, and recognizing that it was something that was indeed achievable.
Yeah. It became attainable at that moment for you.
Exactly.
Sure. So when you, I guess, go to residency, you apply for all these neurosurgery residencies. And of course, it's sort of a lottery program, right? So
Right.
How did you decide what schools or programs that you wanted to go through?
Well, first of all, the path is very difficult.
Yeah.
And even getting into medical school, the path is very difficult. And what I
Oh, yeah.
tell all the young students is, you have to play the percentages. Meaning, I don't know, unless you're an absolutely top flight student and you've scored the best on absolutely every single test, you have to apply to X number of schools, and then, you're going to expect that some reject you. And then,
Yeah.
you'll send out secondary applications to, X minus N number of schools, and then you'll
Right.
get interviews to even less, and then you might get a few acceptances. And so when I went into medical school, that's how it was. I think, I applied to something like 20 med schools. I sent out secondaries to 12 med schools. And then out of those 12, I think I got 8 interviews. And out of the 8 interviews, I got 4 acceptances. I'm sure they might do it a little bit differently today, but
Sure.
even going into residency, it's the same thing.
Yeah.
Part of getting into residency is making sure you're the right fit, and you have to go through a match process.
Yeah.
So if you can go away in year 4 and do an away rotation, that gives you an opportunity to work hard, to have the faculty at a particular institution get to know you very well over a course of, say, 30 days. And they'll write you a letter, which could burnish your application, and maybe even decide that they want to select you in a match process. And so that's what I did. I did an away rotation at University of Tennessee, Memphis. I did an away rotation at Mayo Clinic. And then, I was in med school at St. Louis University, and I think I did like 2 sub-internships in neurosurgery at that time.
Uh-huh.
And, I did a really good job, I think, at the University of Tennessee, Memphis rotation. And one of their senior professors, who's now the chairman, Dr. Rick Boop, wrote me a letter. And even though I didn't go there for residency, I ended up going to University of Texas Health Science Center, San Antonio. Having Dr. Boop, having his support in the process was very instrumental in me getting that residency position at University of Texas San Antonio.
Yeah.
So I ended up going there for residency and spent all 7 years there.
So, and it is a long program. When a lot of people think, okay, I go to med school and then I'm a doctor. It's not that way. You go to med school and then you go to a specialized med school.
Correct.
That is your residency, right? And neurosurgery, I think, is one of the longer runs. Obviously, correct me if I'm wrong, but I think it's one of the longer ones.
It is. It's not the longest, one of the longest. It's a seven-year residency. And then if you do a fellowship, it's typically 1 or 2 years after the residency. And so my whole training in terms of post-medical school training was 8 years.
Yeah,
which was
because you did a fellowship.
Yes, I did a fellowship as well. Yeah.
Which, and I'm assuming that's where you learn things like the deep brain stimulation techniques that we're going to talk about later.
Right. So residency is a unique experience. You start off as an intern, and you're on the floor just running down orders and making sure that the patients get what they need. And then as you matriculate up through the residencies, years 2 to 5 and 6, then you get into the operating room and you're operating a lot more. And then finally, in your 7th year, you're the chief resident, and you now govern the schedule for all of the other junior residents. And then as the chief resident, you kind of get your pick of cases. So as I was coming up through residency, going into years 4 and 5, I would get thrown in the functional cases, which are the deep brain stimulation cases, stereotactic neurosurgery cases.
Yeah.
And, they were tough cases. They were tedious. It took a long time, but I was drawn to the process. Suffice it to say that as I was approaching the end of the residency, I enjoyed it so much, the deep brain stimulation cases, that I said, you know what, I want to go ahead and get another year of training in this area. And so we liken fellowship to kind of like finishing school. So you go through residency and it's a great experience. And some people come out and they practice right away. But if you really want to practice a subspecialty at a very high level, then you need to go and do a fellowship in something. That way you can get that highly concentrated, very intense 1-year training in that one thing in which you're going to focus as your subspecialty.
Right.
So that's what I did. I went to Oregon Health and Science University, worked with a stalwart of our field, Dr. Kim Burchell, for a year, and then came to Kansas City to practice.
So you came to Kansas City to practice. Did you start out at St. Luke's where you are currently, or?
Yeah, I came right out of fellowship. I've been here for 9 years.
Yeah.
And Kansas City community is a great community. They serve a lot of outlying kind of rural areas around here from like maybe a tri-state region. And so the catchment basin is essentially, it results in a very large patient population. So for me and what I treat, deep brain stimulation for Parkinson's disease and essential tremor, this was a very fertile area where I could make a big impact.
Yeah. And it sounds like that's sort of one of your drivers, is wanting to make an impact on a patient population.
Absolutely. Absolutely. At the end of the day, it's treating the patient that's right in front of you. But at the same time, I knew that the Midwest would be an area where there would be a lot of patients who need someone who has the skill set that I have.
So I'd like to talk a little bit of time about, the past 9 years of your life, post-residency / fellowship, right? And your focus being of deep brain stimulation. I know, and I think maybe it's just because maybe a lot of famous people have had Parkinson's. That's the one that comes to mind when I think of movement or mobility issues. But there are other issues, correct, other than just Parkinson's. So what are some of the other issues that could happen?
Yeah, so Parkinson's disease is number one. Essential tremor is another one.
Okay.
And then also dystonia. So right now, the FDA states that deep brain stimulation is approved for Parkinson's disease, essential tremor, and also dystonia via something they call a humanitarian device exemption. So Parkinson's disease is something that it can affect you really almost at any age, maybe from age. There's some people who get early onset Parkinson's in their late 30s, early 40s.
Yeah.
But certainly around age 60, 70, this is when most patients have Parkinson's disease. It's a disorder of dopaminergic neurons in the brain. You start walking slowly, you develop a shuffling gait, you have a ton of rigidity, and some people have tremor as well.
Yeah.
It affects you to where you lose your mobility. It can be a painful disease as well, because if you can't move and adjust yourself because you're rigid, then pressure points start building up and it starts becoming very painful. And then you lose your ability to do your normal activity of daily living, which I think is the most important thing.
Sort of your independence.
It's your independence, right?
Yeah.
And so deep brain stimulation offers them a particular opportunity to retain the function that they would otherwise lose as they go through the course of the disease.
So with the deep brain stimulation treatment of that, is it a silver bullet? Is it sort of a dual treatment that you need to do with deep brain stimulation and other maybe therapies or things like that?
Deep brain stimulation it's a continuation of medical therapy. So at first you can try something called levodopa carbidopa, which essentially is a medication that tries to maintain your dopamine stores within your body and get dopamine past the blood-brain barrier into the brain and increase the duration in which it acts. As time goes on, those types of medications become less efficacious. And then that's when you pivot and bring on deep brain stimulation as a therapy. The goal of deep brain stimulation is not to get off of medication therapy, but it's to maintain your quality of life throughout the course of the day. Many people, when they take medications for DBS, have what we call on-off fluctuations, where you'll take a medication and then you'll limber up and you can do most of your daily things. And then after maybe 2 hours, the medication wears off and now you're stiff as a board. You can barely move. That's called your off periods. So we call it on periods and off periods. And this fluctuation throughout the day can be just very debilitating for the patient. What deep brain stimulation allows you to do is to maintain that best on time throughout the day. When patients go to deep brain stimulation and they see the benefit of the therapy, most of them are very happy with it, as are their family members.
So is the deep brain stimulation used to extend the amount of time that the on period lasts?
That's right. That's a good way of thinking about it, right?
Okay.
It extends that on time. And then as you continue to work with your neurologist, they'll continue to adjust the medications to really stabilize that on time throughout the course of the entire day.
So the goal is to have that on time last the entire day, I would imagine.
That's exactly right.
Okay.
Yeah.
So,
or as close to it as possible.
Sure. And now I know just from talking to other neurosurgeons and just common sense in general would dictate that everyone's brain is very, very different. So I'd imagine finding the right medical or medicine and deep brain stimulation approach is very unique to each individual. Is that the way it is?
It is. The technique of the surgery is pretty similar, patient to patient. There are areas in the brain where you can place these electrodes, either in the globus pallidus internus or the subthalamic nucleus, and you really want to get those electrodes in the proper location and place them as accurately as possible. Now, that being said, once the surgery is done, then the neurologist can then modify and adjust the amount of stimulation so that the patient then gets the best effect. So you can adjust the pulse width, you can adjust the frequency, the voltage to minimize any side effects and then maximize the benefits.
So you're really sort of, maybe a lot of the surgeries are the same or similar at least, but then when you're sort of dialing in each patient's settings, maybe between medicine and the deep brain stimulation. So let me ask this. So you're implanting these electrodes in their skull, I'd imagine. What is the electrode actually doing? I'd imagine it's stimulating a part of the brain, which is sort of built into the name of what it is, but how does it exactly do that?
Yeah, so the operation's done through two kind of burr holes that we make. So we make little openings in the skull, roughly the size of maybe a nickel or so. Okay. And then open the dura, which is the covering of the brain. And then we stereotactically implant two electrodes, one on either side of the brain in most cases, down to the target nucleus. Now, the diameter of an electrode is roughly, say, maybe 1.2 millimeters. And we want to place this to within maybe 1.5 millimeters accuracy of where we intend to place it. So there's equipment that we use in the operating room, from computers to different stereotactic equipment, to make sure that we can coordinate where the tip of the electrode ends up in an X, Y, and Z plane. Once the electrode is down to the target, then we secure it in place. And then the next part of the operation, which is often done on a second day, is to implant the battery. So the battery is like a pacemaker almost that lives beneath the skin. We implant it on the front part of the chest, just below the clavicle in most cases. The lead wires from the brain go down to the battery, and then the battery is essentially, it has its own computer system in it that can then deliver the electrical impulses to the nucleus to then modulate the function of the nucleus.
I didn't realize that they had like a battery under their skin. That's interesting. Yeah. So how long do those last? I mean, I'd imagine they last years and years and years.
Well, they're getting better almost every year. So, there's several companies on the market now that have deep brain stimulation systems. The one that's been on the market the longest is, we won't talk essentially specific names, but
sure.
Their battery lasts about 5 years.
Okay.
And there's a new battery that came out that lasts a little bit longer. Some other companies have now rechargeable batteries where Every
Oh,
couple of
wow.
days, you have to recharge it, and those can last maybe up to 9 years, a little bit
Okay.
longer.
Okay.
It just depends on kind of what the patient requires.
Yeah. Where do you see innovation moving forward? Not necessarily with the medical devices, but also techniques that are used in surgery or anything like that in this deep brain stimulation space.
Yeah, so battery technology is changing quite readily. There are, companies out there that are doing, different things. They're innovating in different areas, and all of it, I think, is good.
Yeah.
There's one company that is doing something like brain sense technology, where you can sense the brain waves as you kind of go through these on-off fluctuations of Parkinson's disease,
Uh-huh.
and then can then change the impulses that are delivered to the nucleus to try to counteract kind of where you are um, in your kind of your waveform as it pertains to Parkinson's disease.
Yeah.
So if you're having an on period, then the battery would kind of ease up in terms of how much impulses it gives you. And then if you're in an off period, then it'll give you a little bit more. So it's intuitive in that respect.
Yeah.
There's other companies that are actually looking more at the lead technology. So we talked briefly about accuracy. And you really want to get your leads placed as accurately as you can, because if
Within
you're
a
a little bit
millimeter, you
off,
said.
right, then
Yeah.
then you can get into side effects. So there are some companies out there that have what we call steering technology. So say if I wanted to place my lead in position X, but then say maybe I'm 2.5 millimeters lateral to that, I can now change and direct the current to where it's directed back medial to get back into the good range of where I want it to be in the first place. And so that allows you to have better stimulation
Yeah.
minus with less side effects.
Yeah.
But the other innovation that really I was kind of on the forefront of is what we call a sleep deep brain stimulation. In the past, you had to do this awake. You'd put on the head frame, the patient would be awake.
Yeah.
You'd go to MRI awake. You'd do the surgery completely awake. I just got lucky in my fellowship. Dr. Burchell had pioneered a new asleep technique, and I was one of his first fellows that he taught how to do deep brain stimulation completely asleep. And so when I came here to Kansas City, I was the first one in the Midwest doing it this way, which I think opened up deep brain stimulation to a wider array of patients. Because if you told someone, well, I'm going to have you do a 5-hour operation, you're going to have to be awake the entire time, that's real scary. And then what
I
if
would
I
be
said,
very
well,
scared by that. Yeah.
right. And then if I said, well, okay, what if we could do the operation in half that time and you could just be asleep? So when you go to sleep, when we get started, when you wake up, you're in the recovery room and we're done. So that was a much more palatable option for a lot of patients
I'm
who
sure.
needed to undergo deep brain stimulation. Since then, I would say in the last 10 years, there's been numerous other physicians and surgeons in the space that are now doing it asleep. It's quickly becoming the industry standard.
Yeah.
So I mentioned that to just say that innovation happens on the technology side, on the surgeon side. Technology always wins. That's what I always tell people.
Yeah, absolutely. Especially if you have something that's both good for the surgeon and good for the patient. Because you
Right.
said, the patient could be asleep, but also you mentioned you could do it in half the time, which I'd imagine as a surgeon, you're much more attracted to do a surgery that takes 2.5 hours over 5 hours.
Absolutely. And the risk to the patient is less. The
Yeah.
less time you spend in the operating room, the less time you spend operating. That's, the less risk of infection,
Yeah.
things of that nature, less time under anesthesia. So all of that's good for the patient.
Absolutely. And you mentioned that's sort of an innovation that's taken off over the last 10 years. And the majority of that time you've been at St. Luke's, it sounds like. But as we were
Right.
talking beforehand, you mentioned you have a little bit of a transition coming up. So do you want to talk about sort of what that transition is and why you decided to make that decision?
Yeah. So, I've been at my current job for about the last 9 years, a little bit more than 9 years,
Mm-hmm.
and it can be a grind. I think physicians are not immune to the things that might affect almost any other person. So, after working hard for 9 years, doing over 400 cases a year,
Oh, man.
With no let up in sight, I kind of looked around. I have a wife and I have two young kids,
Yeah.
and I said, you know what, I need to spend a little bit more time with them. And I really wanted to get back to just the basics of why I went into neurosurgery in the first place, which is to take care of patients at a time when they most need it. And so, what I've decided to do is, at the midpoint of my career, is opt for a change that's going to allow me to continue to practice medicine in a very robust way, to treat the patients that are actually in need of my help the most, particularly patients that come in through the emergency room with a very bad neurologic issue. And then on the other side of the coin, it would allow me an opportunity to see my family some more, and also, do those things that I enjoy here at home.
Yeah.
So, it's something called locum tenens, and you are contracted out with different hospitals who need neurosurgical coverage, and they could either be short-term contracts or long-term contracts. And you go to those hospitals and provide the care that they need. It frees you up to be a neurosurgeon first and foremost.
Yeah.
It takes you out a little bit of the things that can kind of grate on you from day to day, such as maybe the politics or of the hospital, or the things that
Sure.
ebb and flow, and it allows you to really focus in on really just being a physician, being a
Yeah.
neurosurgeon, helping the patient. And for me personally, I'm optimistic that I can continue to do a lot of the things that I do in my subspecialty. One thing I know about, being a physician, any type of physician, is that if you have the expertise, then the need will follow.
Yeah.
And so, I'm looking forward to the change, which is going to allow me to spend more time with my family, and also to practice medicine kind of a little bit more in a manner which I think is going to be sustainable. And I would dare say, as the millennials kind of come into being physicians and neurosurgeons and other specialists, I do think that hospital systems are going to have to look at how they employ physicians, because I think gone are the days like for my dad, where my dad would drive around to four different hospitals. He was on
Yeah.
call 24/7. He essentially just worked and worked and worked and worked and worked, and that was the badge of honor.
Yeah.
One thing that I think the younger generation has gotten right is that there's a need for balance,
Yeah. That work-life balance.
that work-life balance. And it's something
Yeah.
that I really kind of respect the millennials for pushing to the forefront as they've come into the workforce, saying, hey, we're willing to work hard, we're smart, we're driven, but at the end of the day, I want to get to that soccer game. I
Yeah.
want to get to pick up my kid in that receiving line in school. I think those things are very, very important. And I think as we move into the next decade, the idea of what a physician is going to look like in terms of, that person who's just always in the hospital 24/7 from 6 a.m. till 8 o'clock at night, that's going away. And so, there's going to need to be a way in which hospital systems look at that and address it, and retain the value of their young workforce.
And it sounds like, and correct me if I'm wrong, but it sounds like with this work that you'll be transitioning into, you'll be available at more hospitals than just the one that you're currently at. Sort of like the way that your dad would travel around to four different hospitals, you might be contracted with four different hospitals in your area. And it sort of opens up your skill set to a wider audience of people, for lack of a better term.
Yeah, that's kind of how I'm looking at it. And I think that it's going to, if we were going to fast forward, say 10 years from now,
Sure.
I would think that some models similar to this would be how most physicians, including surgeons, are working.
Yeah, I could definitely see that, especially because surgeons are on the high end of the skilled labor that happens in an OR. There's a lot of skilled labor that happens in an OR that is not a
Absolutely.
surgeon, but I see the surgeon as like the head of that team, if that makes sense. So I
Right.
think that position gives you a lot of power to do sort of that, for lack of a better term, sort of contracted work.
Absolutely. I agree.
So let me close with this one final question, and that is simply, if you were talking to somebody who was in that time period when they're trying to decide what specialty they want to go into, what
Right.
would be your sales pitch, for lack of a better term, to get them to go into neurosurgery as a specialty?
I honestly, I don't think I would give them a sales pitch.
Okay.
Neurosurgery attracts the people who really can't see themselves doing anything else.
Okay.
And so maybe that's what I would say, which
Yeah.
is if if you enjoy neurosurgery so much, or you aspire to become a neurosurgeon so much that you can't see yourself doing any other specialty, then come into the field. We'll welcome you with open arms and train you to be a neurosurgeon. But you have to have that drive as you're going through training to even get through the training. That 7 years is a very long time. It's very difficult. And, people don't go easy on you in residency. It's a very, very tough training.
So that's what I would essentially tell you. If you have the drive to do it, you can't consider yourself doing anything else, then welcome. If, however, you're saying, well, I like neurosurgery, but then I also like, internal medicine, or I also like, pathology, then I'd say, you might want to look at one of those other things, because the road is hard, the road is tough, but it's also very rewarding if it's what you want to do. Excellent. So that's what I would tell them. And the final thing I would say is to look around. I'm very glad to be a neurosurgeon, that I achieved the goal I set for myself a very long time ago. But I also recognize that it's not the end all be all. There's a lot of other ways in life to make an impact. And so even as you're focused on the goal of becoming a neurosurgeon, just look around to make sure that you're not turning your back on another area where you have equal talent or even greater talent. That's what I would tell people.
Excellent. Well, I think we'll end it there. Dr. Stephen Griffith, I really appreciate your time today, and thank you so much for talking to us here on Checking the Vitals.
Excellent. Well, it's glad to be here, and I enjoyed our conversation today.
So did I.